Good to go, sir.
Thank you. Bhaskar, please.
Good morning, everybody. Very happy to meet you all this Sunday after a short break which happened during the South Zone, Kerala. Now we are going for our routine program, monthly CME, online CME by Tamil Nadu ISA. I very happily welcome one of the main city branch, Coimbatore, taking part in this event. Other important announcement I have to make is regarding the CME program that has been announced by ISA National on the 75th year of ISA, which has been communicated to the city branch secretaries and all the office bearers. I request them to follow on the schedule and to continue the programs that has been announced by ISA National. And for this program, I also welcome the Tamil Nadu Medical Council Observer, Dr. Kumar. He will be the observer for today's online program. And I have shared the Google document link in the chat box, wherein everybody can make an entry and as well as the payment. This document will be live up to 3 p.m. today. With this short introduction, I hand over the mic to Dr. Saravana Kumar, the President, ISA Coimbatore. Thank you, sir.
Thank you, sir. Good morning, one and all. On behalf of ISA Coimbatore, it's my pleasure to welcome Dr. S. Kumar, President of ISA Tamil Nadu, Dr. Bhaskar, Honorary State Secretary, ISA Tamil Nadu, Dr. Sudarshan Kasturi, Academic Chairman, ISA Tamil Nadu, Dr. Srinivasan, Honorary Secretary, ISA Coimbatore City Branch, Dr. Giridharan, Honorary Treasurer, ISA Tamil Nadu, and all the practicing anesthesiologists and postgraduates for this webinar. I wholeheartedly thank ISA Tamil Nadu for giving us this opportunity. I hope there will be a lot of take-home message from today's session for all of us, and especially for the PG students in improving patient care. I wish the program a good success. Now I invite Dr. S. Kumar, President ISA Tamil Nadu, to deliver the presidential address.
Thank you, Dr. Saravana Kumar. Respected National Office Bearers, GC members, past presidents of ISA Tamil Nadu, and our state team, Academic Chairman, Dr. Sudarshan Kasturi, President-elect Dr. Ramadharani Ma'am, Secretary Dr. Bhaskar, Treasurer Dr. Giridharan, and today's speakers, Dr. Venkateshwaran from Ganga Hospital, Coimbatore, and Dr. Dinesh Kumar from GKNM Coimbatore, and moderators Dr. Anandi Arul Ma'am, Senior Consultant from Velayudham Hospital, Coimbatore, and Dr. Narendra, a Consultant Pediatric Anesthesiologist from Kanji Kamakodi Trust, Chennai. All the branch presidents, secretary, treasurers of ISA Tamil Nadu, members of ISA Tamil Nadu, postgraduates, and my dear colleagues. A very good morning to everyone. On behalf of ISA Tamil Nadu, I welcome you all for this ISA Tamil Nadu State Academic Meeting. This meeting is organized in association with the ISA Coimbatore. Thanks to Coimbatore President Dr. Saravana Kumar and Secretary Dr. Srinivasan for all their efforts and contribution for conducting this meet. About today's speakers and moderators, they are experts in their respective field. Thank you very much for both the moderators and the speakers for accepting our invite and welcome you for this academic meet. A special mention about Dr. Anandi Arul Ma'am. She is known for cardiac and non-cardiac expertise in the field of anesthesiology. Thank you, ma'am, for accepting our invite. We are in 75th year Platinum Jubilee celebrations of ISA. The Platinum Jubilee celebration already started from August 7th till October 15th. There are various events planned by the National ISA that was communicated to all the branches. We also had our executive committee meeting to convey all the events to the branches, and whatever clarification about those events, please communicate with our State Secretary, Dr. Bhaskar. And please, I request all the branches to actively take part in the events to commemorate our specialty 75th year celebration. Yuva Isakan has planned for 2 days CME on 14th and 15th of October. In that, the speakers should be less than 40 years and chairperson should be more than 40 years. Each state they allotted 1 hour session of CME. So that state can bring their own speakers and chairpersons, and then they can conduct the session for 1 hour in that Yuva Isakan during 14th and 15th. The slot will be allotted mostly on 15th to Tamil Nadu because we are traveling all the way from here. So we requested for 15th because the event Platinum Jubilee celebration is on 15th afternoon to night 12 o'clock. That is what they planned in Gurugram. So the event will be conducted, Yuva Isakan CME, and then Platinum Jubilee celebration will be conducted in Gurugram in October 14th, 15th, and 16th morning. You can come back for the Ether Day celebration at respective fields. So that is what the message. So I request all the branches to identify the speakers of less than 40 years to come forward and to take part in the national CME conducted by ISA, National ISA. So that participation willingness and members should come out with their respective branches names to Dr. Bhaskar on or before 31st August. I request again all the branches to actively participate in Yuva Isakan CME conducted by National ISA. With this, once again welcome you all for this wonderful academic meet. Have a great day. Thank you very much.
Thank you, sir. With this short introduction, I think we have to move to our CME program. I hand over mic to our academic chairman, Dr. Sudarshan Kasturi, sir.
Morning, everyone. Respected President, Secretary, Treasurer of ISA Tamil Nadu, President, Secretary and Treasurer of ISA Coimbatore, Senior past Presidents of the state, National GC members, National Office Bearers, and also all the members who are participating regularly of this CME, which is happening once in a month. Today we have an interesting session of, as routine, we have 2 topics of discussion and 2 eminent moderators to take the session forward. The 2 top moderators, we have one from Coimbatore, Dr. Anand Arul. She's a senior consultant anesthesiologist from Vedanayagam Hospital, and as an intensivist also she's covering the ITU care in the same hospital. She's been working in cardiac anesthesiology for a very long time in Kupsaminadu Memorial Hospital from the year 2003, and very recently she moved out to Vedanayagam Hospital a couple of years ago. And she's been participating regularly in almost many of the cardiac sessions in cardiac updates and IACTA conferences as a faculty, and also has been involved in organizing teaching workshops, airway management workshops, and advanced TE workshops in GKNM in Coimbatore. And she's also done her fellowship from UK, and she's a very accomplished scientific person, and she's involved in many of the academic sessions in different conferences across the country. Welcome you, Dr. Anandi. The second moderator we have today is Dr. Narendra. He is from Kanji Kamakodi Child Trust Hospital, Chennai, and he is known for his quality and acclaimed personality in pediatric anesthesiology. He has been involved in pediatric anesthesiology for quite a time. He started his career in anesthesiology and got a very vast experience for more than 12 years to handle tiny tots for the entire career. And also he's quite skilled to provide anesthesia for all the subspecialties of pediatric anesthesia, including dental, facial-maxillary surgeries, airway, ENT, you name it, he's been involved in that. And he's also one of the expertise pediatric anesthesiologists in the country to provide anesthesia for various airway procedures in children. And one of the team member to get training in the airway surgeries in Italy as well. With this expertise, he's been imparting his knowledge to the postgraduates by conducting a fellowship program in pediatric anesthesia in the Child Trust Hospital, Chennai. And he's also a member of Indian Society of Anesthesiology and member of National Academy of Medical Sciences since 2013. He has got good publications for his credit, and he is also a very well accomplished speaker in many of the national and international conferences. And welcome you, Dr. Narendra, and we're happy to have both the moderators for the session to take through. We have two lectures, as you can see, one from Dr. Venkateshwaran and from Ganga Hospital, and the other one from Dr. Dinesh Kumar from Kusaminada Hospital. The details of the speaker will be introduced by the moderators. Over to the moderators to introduce the speakers and carry on with the session. Thank you so much. Dr. Anandi and Dr. Narendra, you can please take over, introduce the speakers one at a time, and then go ahead. Thank you.
I think Dr. Anandi will be introducing Dr. Venkateshwaran.
Yeah, she's made co-host now.
Madam, we are not able to.
Dr. Sudarshan, can
Dr.
you hear me?
Anandi?
Yeah, can you hear me?
You're audible.
Yeah.
You're audible, doctor.
Okay. As we all know, the global incidence of prevalence and incidence of diabetes is increasing because we have the changing lifestyles, and also because patients live longer. So we have with us today Dr. Venkateshwaran, a senior consultant anesthetist from Ganga Hospital. He has more than 12 years experience in teaching DNB candidates, as well as he's an instructor for the CTLS course. He also is a faculty for many regional anesthesia conferences, not only in India, but he's also been an invited speaker at the World Anesthesia Congress in 2021 at Prague. We have with us today Dr. Venkateshwaran, who's going to talk to us on anesthetic consideration in diabetic foot. Over to you, Dr. Venkateshwaran.
Thank you, madam. Good morning, everyone. First of all, I would like to thank the Tamil Nadu ISA for giving me an opportunity to talk in this ISA webinar. My topic is diabetic foot, the anesthetic considerations. As I don't have any conflict of interest regarding my presentation, and generally we get a consent from the patients because this presentation has got a lot of photographs of the patient's wound as well as the videos. So usually we get a consent from the patient for using it for educational purposes and presentation. So this is the consent form we routinely get, photographic consent form we routinely get from the patients who are getting operated. First, I would like to start with a case scenario. So it's a 45-year-old male, diabetic for 6 years. Sepsis, and the sugars were 546 and HbA1c was 11%. The urea and creatinine were very high. He was jaundiced with a bilirubin of 11 milligrams. He has got elevated liver enzymes and he was got quite coagulopathic also with an INR of 2. The ultrasound abdomen was showing hepatomegaly with ascites. So this patient's plan was to do debridement and proceed. It was an emergency because the patient was in sepsis. So the anesthetic plan was by doing an ultrasound guided femoral and popliteal nerve block. Since the patient has got coagulopathy of INR of 2, so we can proceed with a superficial nerve block like femoral and the popliteal nerve block. First, we gave a popliteal nerve block by ultrasound guidance. So, and this is the popliteal nerve block which was given. You can see that this is the popliteal nerve and the needle is going in plane, and then we just inject the local anesthetic around the popliteal nerve below the paraneural sheath, what we see here. So the drug totally surrounds the popliteal nerve, and this is how a popliteal nerve block is given by ultrasound guidance. Next, we give a femoral nerve block so that just for applying tourniquet and to reduce the tourniquet pain relief. So this is a femoral artery and this is a femoral nerve. We inject 20 ml of local anesthetic around the femoral nerve. So the femoral nerve floats, and then that's how the femoral nerve block is given by ultrasound guidance. So the surgery was started. It was a debridement because it was a necrotizing fasciitis. A debridement was done below the knee with a tourniquet control. And the whole muscles in the anterior compartment of the leg was totally found to be necrotic. That's the reason why that bad wound was there. And then it was removed. And this was the raw area which was there. And this raw area was later grafted with a split skin grafting, which was also done along by femoral and popliteal nerve block after 3 days. So the patient was stable and he was quite discharged later. So introduction. Anesthesia for diabetic foot surgeries is more challenging due to the presence of autonomic neuropathy and multiple comorbid illnesses. The right choice of the type of anesthesia improves the outcome of diabetic foot surgeries. So how will you define a diabetic foot? Diabetic foot is nothing but it's an infection, ulceration, or destruction of the tissues of the foot associated with neuropathy and or peripheral arterial disease in the lower extremity of a person with a history of diabetes. So regularly we have a Ganga Hospital classification of diabetic foot, which has been internationally accepted. They say there are 4 stages. The stage 1 is foot at risk is be only a callus. Stage 2 is in presence of an ulcer without any infection. Whereas stage 3, we call it as a crippled foot, that is ulcer with infection. And stage 4 is called as critical foot, that is infected ulcer with or without gangrene with life-threatening sepsis. So this patients, what I have discussed before in the case scenario, is a life-threatening, is a grade 4. It's called critical foot. So that's why it was done as an emergency procedure. For this diabetic foot, it's a preoperative assessment is valid. So because to find out the autonomic neuropathy, you can see autonomic neuropathy is present in about 40% of the patients with insulin-dependent diabetes mellitus, and it's also in non-insulin-dependent diabetes mellitus. The more important thing is all these patients will be having a peripheral neuropathy. So before giving a block, it is important that you have to document the peripheral neuropathy, what he has got. So this peripheral neuropathy is usually assessed by what is called a sensory mapping of the foot. So what we do is in the preoperative, in the OPD itself, they just map the sensory sensation of the foot with all these instruments where they do with the monofilament. They look for heart perception, look for skin temperature, for vibration, pole perception and everything. And the sensory mapping will be done before doing a surgical procedure. And next, the next most important thing is an autonomic neuropathy, which is persistent with diabetes. This prevalence of autonomic neuropathy is very high, which increases with increase in age and increases with the increase in duration of the diabetes mellitus. And you can also see the cardiovascular autonomic neuropathy can lead to complications like arrhythmias and silent myocardial ischemia in the perioperative period. An autonomic neuropathy of the GI tract, which can produce what is called gastroparesis or gastroesophageal reflux, which can cause aspiration, and bladder dysfunction can cause urinary retention. So the diabetic autonomic neuropathy can be assessed by these simple tests like called sympathetic and parasympathetic tests. So these are the tests. Earlier part of the autonomic neuropathy, the parasympathetic nervous system is involved. And the sympathetic nervous system is involved only in the later part of the autonomic neuropathy. So to test the parasympathetic nervous system, we can look for the resting heart rate. If the resting heart rate is less than 110, it is normal. If it is more than that, we can call it as borderline, and more than 110, we can call it as abnormal. And next we do the deep breathing test with the maximum and minimum heart rate beats per minute for parasympathetic. Normally it will be more than 15. If it is 10 to 15, it is borderline. It is less than 10, it is found to be abnormal. Then heart rate in response to standing, we check with 30th and 50th ratio of the ICG. Then if it is more than 1.04, it is normal. If it is less than that, it is found to be abnormal. The next most important thing is we have to check the sympathetic nervous system, which is checked by what is called checking the systolic BP in supine position, and later ask the patient to stand up and check the systolic BP. If the difference is less than 10, it is normal. If it is between 10 to 20, we can call it as borderline autonomic neuropathy. If it is more than 20, we can call it as an abnormal, then we can call it as severe autonomic neuropathy. And if the patient is not ambulant, we can check the blood pressure response by sustained hand grip. So first you do a diastolic blood pressure. Then after that, you do the recording and then do a sustained hand grip for 5 minutes and then check the diastolic BP. If the diastolic BP after doing the sustained hand grip is more than, if the difference is more than 15, it is found to be normal. Suppose if it is between 10 to 15, it is borderline, and if it is less than 10, it is found to be. So how they grade is the severity of autonomic neuropathy is graded with an early dysfunction is 1 or 2 borderline abnormal tests with response to heart rate, and definitive dysfunction is 2 abnormal tests in response to heart rate, but only 1 sympathetic test is positive, then we can call it a severe autonomic dysfunction. So if an abnormal BP assessment test is positive, then we can call it as a severe autonomic dysfunction. This is how we grade the autonomic neuropathy. Whereas you can see this diabetic foot will always have a lot of comorbid illness. So this is the latest statistics what we got in 2021. About 647 cases, you can see these are all so many patients with a lot of comorbid illness. You can see maximum is a chronic kidney disease, and then ischemic heart disease with low EF, hypothyroidism, chronic liver disease, any type of comorbid illness you say it will be present in the diabetic foot patients. So the anesthetic management of the patient with autonomic neuropathy and associated comorbid illness makes it more challenging to give an anesthesia. And each type of anesthesia has got its own limitations. For example, if you give general anesthesia for a diabetic neuropathy, which is in the severe form of autonomic neuropathy, they will have gastroparesis, which can lead to aspiration. Or the hemodynamic disturbances will be very rapid at the time of induction. The patient may also be having a difficult airway also. And they have a very high chance of developing hypothermia, painless myocardial ischemia, and opioid-induced respiratory depression is very common when you do GA for a patient with severe autonomic neuropathy. Suppose if you go for a neuraxial block for a diabetic foot with severe autonomic neuropathy, they will have exaggerated hypotension and high chance of urinary retention in all neuraxial blocks. And if an epidural catheter can lead to epidural abscess because of the very frank diabetes, and this hypotension following this neuraxial block can produce what is called early thrombosis of the ischemic leg. So in a severe autonomic neuropathy, these are all the problems. Whereas with the patients with having early dysfunction or a definitive dysfunction or in the form of a mild autonomic neuropathy, you can go for a neuraxial block that doesn't produce any problems. Whereas in severe autonomic neuropathy, these are all the problems. So if you say general anesthesia and neuraxial blocks are having all these problems, then what is an ideal type of anesthesia for these diabetic foot patients with comorbid illness and severe autonomic neuropathy? It's going to be the peripheral nerve block, which is very good. And because it is very safe, and it is more important thing is very cost effective. And other thing is you can give an early post-operative feeding for these patients. And also the selection of peripheral nerve blocks depends on the site of surgery. If it is the foot and ankle surgeries, we can go ahead with popliteal nerve block and saphenous nerve block. If it is the procedure below the level of knee, then we can do femoral and sciatic nerve blocks. If it is the procedure is above the level of knee, then we can do what is called lumbosacral plexus blocks. This is the latest statistics of what the regional anesthesia for the diabetic foot surgeries. We can say there is more cost effective because we can see almost all the procedures were done under regional anesthesia. And the general anesthesia, what we give is almost zero for this type of patients. And if we go for regional anesthesia, more than 85% were done under regional blocks. And only very 20% is done under with neuraxial anesthesia. So by doing with peripheral nerve blocks, it's very cost effective for these patients. The perioperative management of diabetes mellitus during the surgery is also very important. The preoperative period always stop the oral hypoglycemic agents on the day of surgery and reduce the long-acting insulin by 25%. If it is an intermediate-acting insulin or a pre-mixed insulin, it is reduced by 50% of the dose. Whereas the patient with continuous insulin infusion, with very high blood sugar, it has to be continued in the critically ill patients. And the most important thing is you have to post them early in the day of the surgery or early in the list. And during the intraoperative period, if the blood sugar is more than 180, and if the duration of surgery is less than 4 hours, where you can predict a minimal fluid shift, you can go with subcutaneous insulin secondarily. If the blood sugar is more than 180 and the duration is more than 4 hours, and if you suspect a major fluid shift, then we have to change to IV insulin. In the post-operative period, all the ambulatory patients, we can continue with the same regimen as pre-op. For non-critical patients, you have to reduce the basal insulin by 25% if the oral intake is less. In IDDM, the starting dose has to be reduced to 0.2 to 0.3 units per kg per day. In patients with insulin resistance, the starting dose is increased to 0.6 to 0.7 units per kg per day. And for the critically ill patients in the post-operative period, continue the intravenous insulin infusion for post-operative period, monitor the blood sugar every hourly, and you can adjust it and change to the non-critical side once the patient becomes during the period of transition. So let us go to the commonest block which we give for the diabetic foot. The most common block what we give is for diabetic foot is the popliteal and saphenous nerve block. Because when you see the dermatome of the leg below the level of knee, the entire area below the level of knee is supplied by the popliteal nerve, and the medialmost aspect of the leg and also the foot is supplied by the saphenous nerve. Suppose if you give popliteal and saphenous nerve block, it gives complete anesthesia below the level of knee. And for these type of diabetic foot, it's always better that you can go for a popliteal and saphenous nerve block. How it is given? It can be given by 3 modes. One is by PNS guidance. We can give it by ultrasound guidance, and finally we can also use what is called dual mode. That is by using both PNS as well as ultrasound. How to give by the popliteal block by the PNS guidance? So you just mark the upper border of the patella and draw a line down, and where it meets with a groove here. So this groove is nothing but it's a groove between the vastus lateralis muscle and the biceps femoris muscle. So in the groove, just take a point about 7 centimeters in the groove from the point where from the mark where you are drawn from the patella, upper border of patella. So the 7 or 8 centimeters is the point of insertion for the needle to give a PNS guidance. So what we do is we just mark the point 7 centimeters, and then we just give a good local infiltration, and then we can start doing the PNS. You introduce a needle, 10 centimeters to be flex needle, and hit the femur and you can come down, you'll get a plantar flexion of the foot. You start at 1.5 milliamps, you gradually reduce the current, and if you have a plantar flexion at 0.3 to 0.5 milliamps, then you can start injecting the drug. So usually we give around 30 ml of local anesthetics into this for the PNS guidance. The next one is by doing a popliteal block by ultrasound guidance. So this is done by posterior approach. So we keep the linear probe in the posterior part of the popliteal fossa near the knee. And once you scan it, you'll be able to see these structures. So this is a short video of the structures where you can see this is the popliteal artery, this is the popliteal artery, and this is the popliteal vein. As you see, when you keep it at the lower part of the popliteal fossa, this is the tibial nerve, and this is the common peroneal nerve. Once you scan the probe up or proximally, you can see this common peroneal and the tibial and common peroneal nerve joins together and form what is called as popliteal sciatic nerve. So this is the point where we have to inject the drug for giving a block. So you can see this videos where we have by in-plane method where we have introduced the needle has gone into the popliteal fossa, and as you inject the drug underneath the subparaneural sheath, this is called as a paraneural sheath. This is the paraneural sheath, what you see, and this is the popliteal nerve. You inject about 10 to 15 ml in one region, and then the most important thing is if you give it at multiple sites, the success rate is very good. So we can see the needle tip is here. You know the nerve is here, so we can avoid nerve injury. We can inject the drug this part of the popliteal nerve, and then later we can come to the other side also. And then once you give the drug, and then we can see the popliteal nerve gets completely soaked with local anesthetics, and it completely surrounds the popliteal nerve. So this is how an ultrasound guided popliteal block is given. Usually how much we take is we take 40 ml of local anesthetic, that is 20 ml of 0.5% bupivacaine and 10 ml of lignocaine with attenuate. So among this 40 ml, we give 30 ml for the popliteal nerve block for both ultrasound as well as PNS guidance if you are doing it separately. Then the next thing, most important thing is after giving a popliteal block, we have to give a saphenous nerve block to complete the anesthesia for the leg. So how we give is we keep the probe, the linear probe in the anterior aspect of the thigh and move it medially. So once you move it, we can see by in-plane approach, that is we can introduce the needle and you can see the needle coming inside. And this is the sartorius muscle, and this is the femoral artery, this is the femoral vein, and this is the saphenous nerve. So inject about 10 ml of local anesthetic lateral to the femoral artery, and then you can see this saphenous nerve will get blocked. So we give the last 10 ml of 40 ml what you have loaded for saphenous nerve block. This gives a complete anesthesia to the leg below the level of knee. Next, we go to the case scenario number 2. So this is a 55-year-old male with a dry gangrene of the leg with very high blood sugars, and he was having a nephropathy with very high urea and creatinine. And more important thing, this patient was having an ischemic heart disease with an EF of 30% with LV dysfunction. The plan was to do an ebony amputation for this patient. So this patient was with severe autonomic neuropathy and comorbid illness. We planned for a lumbosacral plexus block. How we do a lumbosacral plexus block? By PNS guidance. So the equipment what we need is a sterile marking pen and a scale, and 2 ml local anesthetic for local infiltration, and a 20 ml syringe with a 10 centimeter stimiplex needle, and we need a local anesthetic sterile cup. So we take about 50 ml of local anesthetic. That is, we take 20 ml of 0.5% bupivacaine, 15 ml of 2% lignocaine with adrenaline, and 15 ml of saline. So it makes about 50 ml. And this is the nerve stimulator which is needed for doing a lumbosacral plexus block. So the positioning of the patient will be lateral position with slight forward tilt. You can see the monitors are attached because it's a deep block. Then the back is completely prepared. It has to be extremely sterile, and the local anesthetic is flushed into its peripheral nerves, needles, that stimulator needles. And the next most important thing is we start marking the landmarks. First, you have to mark the posterior superior iliac spine, which looks like a small dimple in the back. And then we have to mark the upper border of the iliac crest. And you can see this upper border of the iliac crest is marked. And once you mark it, it comes and meets with the posterior superior iliac spine. After that, you have to draw a line from the upper border of the iliac crest to the opposite iliac crest. So this is called as intercrystal line or the Taffier's line. And this is the most important one. We have to draw it. And then we have to draw the spinal line at the level of the spinous process of the vertebra. And then we have to draw a line from the PSIS upwards where it meets the intercrystal line. So from PSIS, you draw a line parallel to the spinal line. So, and this is this point where it meets the intercrystal line. It will be usually 4 centimeters from the mid-spinal line. So this is uniform for most of the patients. And this 4 centimeter corresponds to the transverse process tip of the vertebra. So the point where it intersects the line from the PSIS to the intercrystal line, this is the point of insertion for lumbar plexus block. So you give a local anesthetic adequately to the skin and subcutaneous tissue, and then later we can introduce the 10 centimeter nerve stimulator needle is inserted into the point, and by about 3 to 4 centimeters, you will be able to hit the tip of the transverse process. And then you have to start stimulating with 1.5 milliamps current. So once you hit the tip of the transverse process, we have to stop it. And you can see this by needling, we'll be able to hit the tip of the transverse process. So beyond that, we can't go. Then after you hit the tip of the transverse process, you have to go either, the needle has to be moved either cephaloid or caudal. And the movement, what you have to do is, you have to go only for 1.1 to 1.5 centimeters anterior to the transverse process. Don't go beyond 2 centimeters. So once you go 1 to 1.5 centimeters anterior to the transverse process, cephaloid or caudal, you will be able to get a quadriceps switch with 1.5 milliamps current. And you can see the quadriceps switch is there, and then start reducing the current from 1.5 milliamps. We can start reducing to up to 0.5, then 0.5 to 0.3 milliamp current. Until that, you can reduce it. If you have a good quadriceps switch at 0.5 or 0.4 milliamps, then we can start aspirating and injecting the drug. And you can see, and while you inject, every 2 ml, you just try to aspirate and inject. So here we give around 20 ml of local anesthetic, what we have noted. This is the lumbar plexus block. So the goal is the distance from the transverse process to lumbar plexus should not be more than 1.5 to 2 centimeters. This is uniform for all patients. Even a thin patient will have same thing, and even a obese patient will have same thing of 1.5 to 2 centimeters. So the start with 1.5 milliamp current, and then if you get a visible quadriceps switch between 0.3 to 0.5, you can start injecting. The possible depth is 6 to 8 centimeters. The volume of the local anesthetic we give is 20 to 25 ml. For pediatrics, it is 0.7 ml per kg. The next is we have to do is called a sacral plexus block by PNS guidance. So you just, for this, you have to mark the ischial tuberosity, and then you start drawing a line from the PSIS, what you have marked, to the ischial tuberosity. This is how it's been marked. And in this line from PSIS to ischemic tuberosity, just select upper 1/3, select a junction between upper 1/3 and lower 2/3. So this upper 1/3 junction is the point where for insertion for a sacral plexus block. So you just give adequate local anesthetic and insert the needle. And once you insert the needle, you can see the needle goes parasacrally, and then it goes parasacral, and you'll be able to see a gluteal twitch. So following a gluteal twitch, if you go further, if you move the needle further inside, you'll be getting a hamstring twitch, and also you'll be getting a plantar flexion. You get a plantar flexion at 1.5 milliamps, that is ideal. Then you start reducing the current. You start reducing the current to 0.3 to 0.5. And if you get a good plantar flexion by 0.3 to 0.5, it's ideal. Then you can start aspirating and injecting the drug. So here also depth is 6 to 8 centimeters. We have to give 25 to 30 ml of local anesthetic for sacral plexus. So for sacral plexus also, after you give an osseous contact with the sacral wing, you redirect the needle either caudally or laterally and do not go beyond 2 centimeters. The end point for the sacral plexus is either a dorsiflexion or plantar flexion at 0.3 to 0.5 milliamps. The depth is 6 to 8 centimeters. Suppose if the patient has got an below knee amputation, they come for a revision above knee amputation. If the infection spreads, then what is an endpoint? Because the foot is not there, we can't see dorsiflexion or plantar flexion. In such cases, you look for gastrosoleus twitch or a hamstring twitch. That is an endpoint for this sacral plexus block. So here you can see a video where a sacral plexus block has been given, and you can see that once you go inside the sacral plexus, you'll be able to see the hamstring twitch or the gastrosoleus twitch. If it is present at 0.3 to 0.5 milliamps, we can start injecting, and then these patients we can do, along with the lumbar plexus block, we can do an above knee amputation, but the patient has already had a below knee amputation if the infection spreads. The third and final thing is the ankle block. So always don't go for a landmark technique, because there is a risk of injury to the blood vessels of the foot, because these are all the end vessels and it can produce ischemia or gangrene. Ultrasound guided ankle block is given very safely for this patient. Because the more important thing is it is painful, where it needs 5 injections for 5 nerves. And other thing is we can't apply a tourniquet for a patient who's having an ankle block. The precaution we have to make is avoid adrenaline containing local anesthetics into the ankle block. So we need 5 nerves to be blocked. The first nerve to be blocked is the posterior tibial nerve. You just keep the linear probe just above the medial malleolus of the foot. And once you keep it, you'll be able to see the posterior tibial artery, and also you'll be able to see the posterior tibial artery here, and this is the tibial nerve. So by in-plane approach, you can introduce a needle and go towards the tibial nerve and start injecting the local anesthetic. About 3 to 5 ml of local anesthetic, you see the tibial nerve will get totally blocked. Next thing is deep peroneal nerve, where we keep the probe in the front of the ankle between the medial and lateral malleolus. And once you keep, you will be able to see the anterior tibial artery and the deep peroneal nerve here. And then you can start injecting the drug, where you can start introducing the needle, and then you will be able to, by 3 to 5 ml of local anesthetic, you'll be able to block the deep peroneal nerve. Then third thing is the superficial peroneal nerve, where we keep the probe 5 centimeters above the lateral malleolus, where you can see this is the lateral malleolus and this is the superficial peroneal nerve. And then once you start introducing the needle in plane, we can see this is the superficial peroneal nerve, and you inject about 3 to 5 ml of local anesthetic, it gets completely blocked. Next one is the saphenous nerve, where we keep the probe just above the medial malleolus, where you will be able to see this is the saphenous vein and this is the saphenous nerve. So you can introduce the needle and start injecting the drug, where you can see the saphenous nerve becomes more prominent. So this we give a 3 to 5 ml for a saphenous nerve block. And finally, the sural nerve, we keep the probe above the lateral malleolus of the foot, and then you will be able to see the short saphenous vein. This is the short saphenous vein, and this is the sural nerve. And by introducing the needle, you'll be able to see the needle go close to the short saphenous vein and inject the local anesthetic, where the sural nerve will get delineated, and this is the sural nerve. So we can give all the 5 nerves, we can block all the 5 nerves for doing a good ankle block. So what are the problems facing during surgery for a diabetic foot? The most important thing what is worsening is the venous tunicate. So after inflating the tunicate, if you see there is excessive bleeding, This is because of the atherosclerosis of the femoral artery, where all the femoral vein gets congested and produces a lot of bleeding. So when there is a lot of bleeding, even with the inflation of the tourniquet, what you have to do is you stop inflating the tourniquet, deflate it, and then we have to do with experienced surgeon and a lot of surgical hands we can do a procedure, or you can inflate the tourniquet with a very high pressure and start doing it. Otherwise, a lot of bleeding will be there if you do it with a venous tourniquet. The next thing is at the time of release of the tourniquet, there is high chance of arrhythmias because of the hyperkalemia happens following the release of tourniquet. We have to be very careful. So always monitor the ECG. We have 1 or 2 patients developing a arrhythmia and cardiac arrest following the release of tourniquet where we have managed successfully. So we have to be very careful while we release the tourniquet, always monitor the ECG. Then in some of the patients, we can go for a, for the regional anesthesia for compromised patients. So we can see this is a patient with a 56-year-old male, and then he has got a Ganga class 4 diabetic foot. He was on ejection fraction was only 30%. He was on non-invasive ventilator, planned for an ebony amputation. So he desaturates once you remove the MA. So we shifted the patient with the ventilator to the operating theater, where so it's not moving. I think next slide. So the patient was shifted into the OT with the ventilator. You can see the ventilator there, and the lumbosacral plexus block was given, and then finally ebony amputation was done for this patient. So this peripheral nerve blocks are quite safe in peripheral neuropathy. So we can always go for a peripheral nerve block with a dual mode by using ultrasound and PNS. Keep to that you get an endpoint at 0.3 to 0.5 milliamps, and keep the injection pressure monitor less than 15 psi, so that will be very safe for the patient with peripheral neuropathy. Whereas, and also if you see for the popliteal nerve is quite safe, and popliteal nerve block is quite safe because in the popliteal nerve, the ratio of the nervous tissue to the connective tissue is 1:2. That is more of connective tissue and less of nervous tissue. The chance of nerve injury is less. Another most important thing is try to avoid tight casting and prevent excessive traction of the POP that you put after operating the diabetic foot. So it's very safe. Then if you do all these things, it's quite safe in patients with peripheral neuropathy. Next is the needle trauma. So we have to be careful that if you select a needle like 22 or 24 gauge needle, the nerve injury is less. If you select a larger size needle, nerve injury is more. And one more important thing is selecting the long bevel and short bevel needle. If you select a long bevel needle like this, the long bevel needle will have an end cut at 12 to 15 degrees. So here, in this cut, the chances of nerve injury is quite high, or a fascicular injury is quite high. Whereas if you select a short bevel needle like this, where the tip is cut at 45 degrees, the chances of injuring the fascicles is quite less. So finally, the take-home message is the autonomic dysfunction and with other comorbid illness, so it has to be assessed before surgery for all the patients with diabetic foot. The peripheral nerve blocks for these type of patients is quite challenging, and it is quite safe and cost effective. The nerve injury can be prevented by using the dual mode by nerve stimulator and ultrasound. The lumbosacral plexus block gives a complete anesthesia to the entire limb, so any surgeries can be done. And more importantly, the peripheral nerve blocks gives a prolonged post-operative pain relief, and it's very good for the patients with a very good post-operative pain relief. Thank you so much for your patience here.
Thank you, Dr. Venkateswaran, for a very, very nice lecture on the importance of peripheral nerve blocks in diabetic foot. I think we all go home with a feeling that we have to give only peripheral nerve blocks for all diabetic foots. I think the peripheral nerve blocks that you have demonstrated is all for patients who are really sick with all the end organ dysfunctions, with the uncontrolled diabetes. I think peripheral nerve blocks is the anesthesia of choice. But my question is, do you do spinal anesthesia as well? I think many of us are not as good as you all in giving lumbosacral and sacral plexus sciatic nerve blocks. I think they are all little blocks which have which needs, the learning curve is quite high, and the failure rates are there in patient in anesthetists who are not used to it. So do you recommend, do you not do spinal anesthesia at all, or a spinal anesthesia is an option in other group of patients?
Yes, spinal anesthesia is also an option in certain group of patients. When you assess the autonomic neuropathy, if the autonomic neuropathy is mild, not a severe type of autonomic neuropathy, and if the patient doesn't have a very serious comorbid illness like a low ejection fraction, and also with some other bad comorbid illness, for those type of patients, we can subject them for spinal anesthesia, and nothing much happens for those patients with early autonomic neuropathy or mild autonomic neuropathy. Whereas for a severe autonomic neuropathy in very sick patients, we can see that it produces a lot of hemodynamic disturbances in these patients. So for such patients, we can go for spinal anesthesia.
So what about the diabetic control in these patients? You have nicely told us about how we go about doing the blocks, but how do you actually control the diabetes? Because in all your patients, the blood sugars were quite high. So how do you actually control them? Do you put IV insulin?
Yes, madam. Those patients who are coming with very high blood sugars, we start an continuous insulin infusion for this patient. We give some IV insulin followed by an insulin infusion, and you try to then every hourly we can check the blood sugar. And if the blood sugar is less than 250, that is, so ideal perioperative period blood sugar has to be controlled between 120 to 180 milligrams. That's what the ideal target that we reach. So once you reach that, then we can take the patient for the surgery, and we can proceed with this peripheral nerve blocks.
I have a question to ask. Can I?
Yes,
with permission of the chair. I know of one of the recent medical legal litigation case wherein a diabetic patient was given a regional anesthesia, ended up in some kind of a neurological damage, and they attributed everything to the anesthesiologist. And then, so in these cases, most of them, we expect them to have certain amount of involved neurological disease as well. So what defense you have in saying that this is the best choice for the patient? And suppose if the patient ends up with worsening of the neurological, anyway, the limb is going to be salvaged. You're all conceived as gods saving the limbs. But then, unfortunately, there will be a group of patients who would not accept with the result and end up asking you, you've given a wrong choice to me by putting an injection and then worsening my neurological problem. And then what's your take on that? Pre-existing neurological disease, even the literature doesn't really support that. It's double-edged because post-neurological disease patient undergoing a regional anesthesia, particularly large peripheral nerve block, not even central nerve axis. Central nerve axis, of course, you have your own limitations for several reasons. But peripheral nerve block on a pre-existing peripheral neurological disease, how safe are you? Because as Dr. Anandi mentioned, not everyone have exact access to whatever gadgets you have been mentioning, and then not everyone uses them with the similar expertise for repeated performance. So which will be your advice? I have nothing against doing all this, but what will be your advice for somebody who's worried about person like me? I'm not quite worried about the neurological problems in these patients, and they go to litigate me.
Sir, for all these patients, what we are doing is we are doing a sensory mapping in the preoperative period itself. So we know they just do a sensory mapping of the foot and the leg, the preoperative period. They know which nerve is not very good, and all these things will be analyzed and it is documented. Then the safest point for these type of patients who are very much worried is you go for a dual mode, sir. So the dual mode where we can use both ultrasound as well as the nerve stimulator, and when you use both of them and keep the current of the nerve stimulator between 0.3 to 0.5 milliamps, and you can ask the assistant while injecting, just see whether the patient has got, whether there is any resistance to inject. So we generally keep if there is less resistance in injecting, or sometimes some amount of this nerve pressure monitor is also there, but we don't have in our hospital. We just clinically see how the resistance of the assistant who is injecting the drug. And then if you can do like that by using a dual mode, the chances of nerve injury is absolutely less as per the literature. And also in our lot of patients what we have operated, and they come for the review in the post-operative period, and also the first and second review in the OPD, they also didn't have any possibility of a nerve injury for these patients when you go for a dual mode, sir.
So do you follow them up with the sensory mapping again when they come?
Yes, sir. We follow them up in the sensory mapping in the post-operative period, and also when they come in the OPD, also they do our diabetic foot surgeons, they do a sensory mapping. So this is regular in our OPD because our hospital has got a very big diabetic foot department. The number of cases is about 5 to 6 patients every day they operate. So they just follow it up regularly, and then the chances is very not there at all. I have not seen any patients giving that type of problems.
Any other questions from the?
I think there are some questions in the chat, ma'am, Dr. Anandi. Can we take that? I think Dr. Kumar itself has asked. In the patient with a diabetic peripheral neuropathy and autonomic neuropathy, does the peripheral nerve block increases the neuropathy, and what is the evidence about it? What says about it?
Pardon, the question is peripheral nerve block increases the neuropathy. No, the peripheral nerve block doesn't.
The peripheral nerve
blocks increases the neuropathy. What is the evidence? I think that's what you actually said.
Yeah,
that
I have said actually.
Because you have done the sensory mapping, and in your experience, I think you all don't see.
Yeah, we're not able to.
You don't see
any
worsening of the peripheral neuropathy.
Yeah, it's not there because they are doing a sensory post-op also.
Okay. There's another question from Dr. Bhaskar Natarajan. When can the peripheral nerve block be repeated?
Yeah, so it can be repeated on the, suppose it can be repeated the next day also, because some of the patients come for debridement on one day, and the next day itself they want to cover it with the skin graft. We can repeat the peripheral nerve block the subsequent day also. 24 hours, there is no problem, there is no issues in repeating the peripheral nerve blocks. We have to see that whether the nerve block what you are given is completely weared off, and then the next day we can repeat the peripheral nerve blocks.
There's another question from Dr. Subbulakshmi. Is there any difference in duration of sensory block and analgesia between diabetic and non-diabetics after popliteal block?
The duration
of sensory block, is there any difference?
Yeah, in diabetic neuropathy patients, the sensory block is quite prolonged. They don't have much of pain in the post-operative period, and we can see to almost up to 18 to 24 hours the sensory block is there for these patients when you compare with normal or young patients without peripheral neuropathy. There's a prolongation of sensory nerve block.
Is it with plain local anesthetic, or you add any additives along with that?
We don't add any additives for these patients. We use only bupivacaine and lignocaine for this. So we don't add additives.
And what is the reason for these prolonged blocks? Usually, 6 to 8 hours is okay if you do not add any additives. But further than that, does that mean it increases the neurotoxicity? So there has been a lot of reports saying that neurotoxicity is increased.
Well, maybe the possible this thing is the sensitivity of that peripheral the nerve filaments, nerve fibers to the local anesthetics, and that's the reason why it's getting prolonged. Actually, we are not analyzed for the prolonged blockade for these type of patients. Maybe because of that mild amount of peripheral neuropathy having the sensitivity towards the local anesthetic is quite high. That's why the duration of sensory block alone is getting prolonged for this patient. That's what I think, madam. I don't have any literature review or any latest evidences to show that why it is like that in patients with peripheral neuropathy.
Dr. Sudarshan wants to know if you've had any complications while giving all these blocks? Because you seem to be giving even for INR of 2. I mean, I would be a little reluctant to give. So even with an INR of 2, do you go ahead and give lumbosacral and sciatic nerve blocks? He wants to know if you have had any complications. And what are the complications that you really face?
Madam, in lumbosacral plexus block, there are a lot of complications. The complications is because of the needle placement. Suppose because sometimes this needle placement, it can produce a renal capsular hematoma can also happen if you go above L3. So we just go at the level of L4 to L5, where we can avoid this. This is one of the complications. The second thing is the drug what we inject in the lumbar plexus, sometimes it can enter into the epidural space and it can produce a hypotension. So that alone we have to be very careful. And the other thing is, suppose while needling, if it can injure one of the lumbar veins which are there in the lumbar plexus, and this lumbar vein getting traumatized, it can produce a lot of retroperitoneal hematoma. You have to be careful with such type of this thing. So that's
what
why
are the complications that you
so these are all the complications
that you have faced?
I have faced in one or two patients. We have seen an epidural spread for those type of patients, where we have managed with vasopressors, that we can identify if the opposite leg also getting blocked, then it means an epidural spread. We had one among the 57 cases what we have done, then we have one or two patients having a epidural spread, where it involves the opposite limb because of the drug entering into the epidural spread. That's one of the complications which you have faced. Otherwise, there may be some amount of sparing of the nerves, like some of the nerves, like an obturator nerve gets spared with lumbar plexus block. These are all some of the problems which are faced while giving lumbar and sacral plexus block.
I have one more question. You seem to have a lot of patients with the low ejection fractions, and are these patients on SGLT2 inhibitors in the preoperative period?
Yes,
so
yes.
How do you actually go about managing? Because there are a lot of literature now, a lot of case reports saying that they go into euglycemic ketoacidosis. Do you really face those problems, or how do you handle them?
Very few of them had SGLT. Co-transmitter inhibitor drugs. So these drugs, if they come for an elective procedure, we used to stop this drug for at least 24 hours before the surgery. But while doing a peripheral nerve blocks for these patients not having any problem, then we just monitor the blood glucose level. If it's taken as an emergency, just monitor the blood glucose level, and according to that, we can adjust the fluid or the insulin what we give. Otherwise, we don't face any issues in these type of patients. Elective, we stop it 24 hours. As an emergency, if it comes, we go ahead with the peripheral nerve block and do it off and monitor the blood glucose levels for this.
Okay, I think we are out of time.
I think exactly. We are running out of time, but Dr. Venkat, one more thing. You have any comments on the local anesthetic, newer local anesthetics? Because you told me only bupivacaine, you are using Stenserican only. Are you using any other newer levobupivacaine or ropivacaine?
So far, we are not used to, sir. We are using only 0.5% bupivacaine, lignocaine with that.
Okay, and what about the systemic toxicity? Are you seeing any bigger? I think you are seeing yours is a very high volume center. So are you seeing any systemic local anesthetic toxicity?
We are not seeing any of the patients having systemic local anesthetic toxicity, because we always monitor while giving a block, and we always see to that our OT has got a 20% intralipid in our theater. After that only we go ahead and blocks, and close to monitoring and with intralipid, I don't think we have faced any of these sequences.
Yeah. Okay, I think it's very good presentation, and thanks a lot. Shall we move to other?
I think we need to switch over to the next talk. I think
exactly. Dr. Dinesh.
First session.
Dr. Dinesh can load his slides. Meanwhile, I'm very happy to introduce Dr. Dinesh. Dr. Dinesh Kumar Gunasekharan. He is a consultant pediatric anesthesiologist at GKNM Hospital, Coimbatore. I think Dr. Dinesh has done his postgraduate from Meenakshi University, Chennai in 2012. And after that, he has come to do the fellowship in pediatric anesthesia from Kanchi Kamapati Children's Hospital. It's a MGR recognized university. He got more than 10 years of exposure in anesthesia, I think in India as well as abroad. Here, Dr. Dinesh has presented many papers and he's a speaker in many scientific meetings, conferences. Yeah, his core interest is in pediatric anesthesia, and he has started. That's why he has started IAPA Pediatric Anesthesia Fellowship at GKNM. I think 8 years. I think now almost last 8 years he's running a fellowship program, and he's a course director for that. He's actively involved in ISA as well as Indian pediatric IAPA activities. That's the pediatric anesthesia group activities, and he's supposed to be organizing next upcoming national level pediatric anesthesia meet, IAPA National Conference in Coimbatore in 2023, Feb 2023. So if Dinesh is ready, I think I'll hand over to Dr. Dinesh to throw some light on the pain. I know the pain in that too in the kids. Pain, anybody pain is I think worst scenario, and that too for the kids. So let's hear from Dr. Dinesh now.
Thank you, Dr. Narendra, for the kind introduction. I also take this opportunity to thank ISA Coimbatore and ISA Tamil Nadu for providing me with this opportunity. Today I'm going to talk about pediatric acute pain management, the general principles and what's trending. Mostly all the controversies we're going to be covering about it. So greetings from GKNM Hospital, Coimbatore. We all know that pain is an unpleasant sensory and emotional experience associated to a real or potential tissue damage. We also know that pain is the fifth vital sign. But pain is a very subjective experience and is probably the most bewildering and frightening experience kids will have. I would rather say the pain tolerance to the older generation was much better than the pain tolerance which is to the kids now. So it is very subjective. Despite its prevalence, pain in infants, children, and adolescents is often underestimated and undertreated. I would say the prevalence of pain is often underestimated, whereas the complications of the drugs that we use is always overestimated, and we underuse the drugs. Approximately 50% of inpatients were experiencing moderate or severe pain on an average day, according to the study. And there has been no change in practice from survey performed 16 years earlier, even till today. From the patient side, this is the drawing of a 10-year-old child with severe headache. So it's a depiction of how severely the kids perceive their pain. Basically, our thing is primum non nocere, where failure to treat a child's pain violates the first rule of medicine. And pain control has been the second highest parental priority after a correct diagnosis. Most often the parents are worried about the first priority is diagnosis of the problem, and the second thing is so pain is going to be the most primary concern of the parents. And we all know that the immature nervous system in pediatric patients results in them experiencing more pain in response to a noxious stimulus and not less as it was previously thought. In fact, right from 24 weeks after conception, they start perceiving pain. So ultimately, what most of the children experience is nothing but brutocaine. So there are a lot of societies which are making a lot of protocols. American Pain Society, the Pain in a Child with the British Pain Society, the WFSA, and of late the Society of Pediatric Pain Medicine. They have been formulating a lot of guidelines, and I was privileged to be there in the US for the first meeting. So the goals of effective and appropriate pain management are to improve the quality of life for the patient, facilitate rapid recovery and return to full function, reduce morbidity, and allow early discharge from the hospital. And the long-term negative effects of pain is going to be chronic pain. There's going to be behavioral changes. There's going to be rewiring of the whole neural system. And the types of pain that the child may be experiencing may be somatic, which might be arising from the skin, muscle, or the bones, visceral, arising from the organs within the chest and the abdomen, neuropathic, caused by damage or dysfunction in the nervous system. But more often, children often experience more than one type of this pain. It can be somatic and visceral combined, or somatic and neuropathic combined, or sometimes even somatic, visceral, and neuropathic all combined together. So basically, how we assess pain. There are so many scales, and in fact, there is a whole book on scales to assess pain. It's a lot of confusion. There's a bewildering number of acute pain measurement tools which exist: the Comfort, the FPS, the VAS, the FLAG, the NRS, and on top of it, we have a lot of age groups to which each implies. And there are a lot of pain scale algorithms which basically, work with self-report tools. They work on behavioral tools. They work on physiological tools. So the recommended measures for procedural and post-operative pain assessment as a function of the children's chronological age, mostly newborn to 3 years, it's either the Comfort or FLAG scale. 4 years old, it's FPS, Comfort, or FLAG scale. 5 to 7 years, it's FPS. 7 years old, it's FPS or VAS or NRS. So, combining all the age groups, we can say up from newborn up to 4 years, we can either use the Comfort or FLAG scale. And above 4 years, we can use the FPSR scale. So FLAG scale is nothing but 0. It's face, legs, activity, cry, and consolability, which has a score of 0 to 2. And the maximum score is 10 and the least score is 0. And we all know the visual analog scale, the FPSR scale, which is the revised one. So what is the strategy? How are we going to treat the pain actually? There are so many confounding factors in pediatrics when we have to treat a child's pain. Patient factors, there are 2 sexes, there are 4 age categories. There's the physical health, the mental health, the genetics of the child, and the previous experience with pain. All these are confounding factors as far as the patient is concerned. And surgical factors, there are 21 specialties. Each specialty has a different threshold for pain. There are more than 2,500 procedure codes, and in fact, there are more than 20,000 procedures which are performed on children. And our own anesthetic factors, there are 5 classes of anesthetic agents, there are 3 classes of analgesics, there are 10 classes of adjuvants, and more than hundreds of local and regional techniques. And other acute pain strategies, there are 2 psychological strategies and 4 physical strategies. So there are so many confounding factors, and how are we going to actually target the child and deliver it? So the pain prevention and intervention, it's the 3 Ps approach, which we all know. It's the pharmacological, which is the WHO ladder, and the adjuvant treatment. And we have the physical, where we have eyes, heat, positioning, TENS, and massages. And we have the psychological approach, where it's education. We have a lot of distraction techniques, especially with a lot of digital screens at our access now, and there are relaxation techniques as well. So the strategy would be to attack all 4 phases of nociception, which will be the transduction, transmission, modulation, and perception. So at the level of transduction, NSAIDs work. At the level of transition, neural blockades, modulation, where opioids do a great job, and perception through pre and post-op teaching, which also prevents anxiety. So at the nociception level, we have the NSAIDs, local anesthetics, the cooling and heating techniques. At the afferent levels, we have local anesthetics. At the level of spinal cord, we have opioids, local anesthetics, and adjuvants. At the ascending and descending pathways, again, we have opioids and local anesthetics. At the level of brain, we have paracetamol, opioids, adjuvants, and a lot of psychological techniques. So going one by one, we'll start with the pharmacological methods. As per the pharmacological methods, the 2020 WHO guidelines, where we go by the clock, by the child, by the appropriate route, and by the ladder. We know the ladder. Mild, we start with paracetamol, non-opioids, and ASIDs. Moderate, we use weak opioids, and severe, we use strong opioids as the pain increases. So going by the pre-op techniques, intra-op techniques, and post-op techniques. Pre-op, there are a lot of books on pediatric pain management. This is the one written by Dr. Tobias from Nationwide Children's Hospital in the US. And this is the pediatric anesthesia textbook written by Dr. Bruno Bissonnet from Canada. And I've had the opportunity to be with them and observe them at work for nearly 15 days each. And most of them follow these methods. Pre-op, when the child does not have an IV line, this is a fantastic way of drug delivery, the intranasal drug delivery, where we use the atomizers to deliver the drugs. What you see here is the atomizers. Intranasal, the absorption of the drug is as rapid as IV route. In fact, there are a lot of procedures under safe environments without IV route. Just with intranasal, the procedure is done with in a child. Fentanyl 2 mg per kg, the peak effect takes around 3 to 5 minutes through the intranasal route. Ketamine around 2 mg per kg, the peak effect again takes 3 to 5 minutes. And Dexmed is used at the dose of 1 mg per kg, and again it takes 3 to 5 minutes to start acting. And preoperatively, we use a lot of EMLA cream for IV lines, for spinals, and for any prick pain. Intra-op, we have the regional anesthesia, which is the best, like the previous talk. This is Dr. David Polander, and his study says over a large multi-center prospective audit of regional anesthesia in children, there is a very low rate of serious complications using regional anesthesia in children. So it's very safe to use regional anesthesia in children. And suggested maximum doses of bupivacaine and ropivacaine, a single bolus injection, maximum dose, neonates we can go up to 2 mg per kg, and in children 2.5 mg per kg. For continuous infusions in neonates, we can go up to 0.2 mg per kg per hour. And in children, we can go up to 0.4 mg per kg per hour for continuous infusions. Caudal epidural for major abdominal surgeries, 0.2% ropivacaine is used at 1 ml per kg, and 0.25% bupivacaine at again 1 ml per kg. For minor surgeries, ropivacaine at 0.6 to 0.8 ml per kg, and 0.25% bupivacaine at 0.6 to 0.8 ml per kg again. The additives that we very commonly use is clonidine, which gives a nice prolongation and a very good heart rate. Clonidine at 1 to 2 mg per kg. We also use Dexmed at 1 to 2 mg per kg. Ketamine, preservative-free at 250 to 500 mg. Morphine at 15 to 50 mg. And fentanyl at 0.5 to 1 mg per kg is used in caudal. But most oftenly, we prefer using clonidine and dexmedetomidine. And I would also like to bring the importance of dexamethasone in combination with caudal analgesia. With a lot of evidence, we can say that IV dexamethasone with caudal, it augments the caudal block, the intensity and duration of postoperative analgesia without any side effects. So next, nerve blocks. This is my mentor, Dr. Ramesh. He always says, whenever possible, wherever possible, you have a nerve in a child, please do block it so that the IV requirement comes down, and we can wake them up fast, and we can facilitate their discharge and other things. There are a few things which we don't know that we don't know, and this might be one such thing. It's a very pictorial representation of how the drugs that we give and the local and epidural that we give act. Opioids, it affects the entire body of the child, whereas epidural nerve block affects the region of the body. The peripheral nerve blocks affects the limited region of the body. So the local nerve block affects the local surgical site. So ultimately, as a result of low rate of complications, RA techniques have a good safety profile and can be used to provide postoperative analgesia. In addition, the results should encourage anesthesiologists to continue to use peripheral instead of central blocks as often as possible when appropriate. So for example, when we have a circumcision, it's better to go for a penile block than to actually give a caudal block. Common peripheral blocks, head and neck. We use supraorbital for craniotomy, VP shunts, and plastic surgeries. Infraorbital, we use for cleft lip and nasal septal surgeries. Greater palatine blocks, we use for cleft palate. In fact, there are times when we get at smile train camps, we got to use only the blocks when opioids were not available. Occipital for craniotomy, frame of stereotactic surgeries. Common peripheral nerve blocks, upper extremities. Most of you might be knowing this person. This is Dr. Suresh Sandhanam. He's done a lot of work, and whichever paper you take about an upper extremity nerve block, his name is there. So brachial plexus blocks, we use axillary in pediatrics, interscalene is used, supraclavicular is used mostly for shoulder, elbow, forearm, and hand surgeries. We use a lot of wrist block for finger injuries and finger blocks. So these are the most commonly used upper extremity blocks. And common peripheral nerve blocks, abdominal, we use the tap block, we use the rectus sheath block. More often, we combine the rectus sheath and the tap block for abdominal wall surgeries and lap surgeries. And we also use the ilioinguinal block for hernia and groin surgeries. And we use the spermatic cord blocks a lot for torsion testis and other cases, hydrocele. And the common peripheral nerve blocks, lower limb, we use femoral for thigh biopsy, knee surgeries, where we try to avoid using a general anesthesia for obvious reasons. Sciatic, popliteal sciatic for foot, ankle, and knee surgeries. And we also use a lot of ankle block in children. Drugs, the most commonly used is acetaminophen. Paracetamol improves analgesia after a minor and major surgery in children. It also has a lot of opioid sparing effects of perioperative paracetamol and NSAIDs in children. Paracetamol dosing guidelines, very often we are mistaken. The oral dose is around 20 mg per kg for more than 3-month-old children, and the rectal dose is not 10 or 20, it's 40 mg per kg. And the IV paracetamol dosing, less than 5 kilos, we give up from 7.5 mg per kg, 5 to 10 years, 10 mg per kg. And 10 to 50 kilo children, we give up to 15 mg per kg. And more than 50 kilos, we definitely recommend 1 gram paracetamol. Rectal uptake is very slow and very variable. So doses of 20 mg per kg is not often therapeutic, and it takes 2 to 4 hours to reach therapeutic concentration. So therefore, per rectal, 40 mg per kg followed by 20 mg per kg doses are recommended. NSAIDs reduce opioid requirements, improve postoperative pain intensity, decreases the postoperative and nausea. NSAIDs and bleeding, there is always controversy. 2018 updated systemic review of 36 randomized controlled trials said that there's no apparent effect of NSAIDs on risk of bleeding after tonsillectomy. And in fact, in the spine journal also, there were 2 separate studies which mentioned there were no evidence of a deleterious effect. 2 retrospective reviews looking at the use of NSAIDs following pediatric spine surgery. No difference in incidence of non-union in patients receiving ketorolac versus control groups. So NSAIDs and bone fusion, I think the controversy is sorted. So the most commonly used NSAIDs, we use diclofenac, ibuprofen, ketorolac, diclofenac mostly 1 mg per kg, ketorolac 0.5 mg per kg. Ketamine is back. Ketamine is like the old wine in the new bottle. NMD antagonist, ketamine, it's very well tolerated in children at low doses. There is no nausea, there is no increased secretions. Meta-analysis of more than 35 randomized controlled trials say that perioperative IV ketamine has overall decreased PACU pain intensity and analgesic requirements. In fact, we also use it locally for tonsillectomy, post tonsillectomy cases, and their analgesic requirements again is very less. So ketamine, just like life begins at 40, ketamine has started coming up in a very big way now. The dose that we use is 0.25 to 0.5 mg per kg as an initial bolus, followed by 50 to 500 mics per kg per hour. And it can be used in any route: oral, subcutaneous, IM, intraspinal, epidural, rectal, and intranasal routes. Next best drug that we have in our armamentarium is dexmedetomidine. 11 randomized controlled trials. Children who received dexmedetomidine, they were at lower risk for postoperative pain, reduced postoperative opioid requirements, and in fact, they're very calm and there's no respiratory depression. Opioids remain the most powerful and widely used group of analgesics. They can be given by many routes of administration and are considered safe, provided accepted dosing regimens are used and appropriate monitoring and staff education is in place. So the general rules for narcotics, route IV administration or nasal, it takes around 3 to 5 minutes to achieve peak effects in children. Subcutaneous or IM, it takes 20 to 30 minutes. Oral, it takes 60 minutes, like fentanyl lollipops and other things. Patches, it acts for it takes around 8 to 16 hours to reach the peak effects. Controversies. Opioids for pain relief, they rarely cause addiction because the access and the duration of use is very short. And we have to be aware of opioid-induced hyperalgesia. The use of opioids, there is no serious harm. In fact, it is comparable to pediatric epidural infusions, which is just 1:10,000 serious harm. So I think opioids, we don't have to be really scared to use opioids in children, but we have to use them judiciously. Opioid potency relative to morphine, tramadol is 0.1 times potent as when compared to morphine. The dose is 1 mg per kg in children. We usually use it for kids more than 20 kilos. And for continuous infusion, tramadol 100 to 40 mg per kg per hour. Morphine, it is used at the dose of 0.1 mg per kg, and continuous infusion is done at 10 to 40 mg per kg per hour. Fentanyl, it's in fact more 50 to 100 times more potent than morphine, and the dose used is 1 to 2 mg per kg. And for continuous infusion, we use 0.5 to 2 mg per kg per hour. And this wonder drug, which is yet to come to India, even in fact, yesterday we were discussing with Dr. Sudeshan sir in the Coimbatore ISA meeting yesterday. Remifentanil will become the one-stop solution in pediatrics for sure. It will be the switch on and switch off analgesic. In fact, for a lot of muscular dystrophy patients, we can perform relaxant-free anesthesia where we can avoid a lot of malignant hypothermia and other things. Wish we have it in India soon. Remifentanil, it is going to do wonders in pediatric anesthesia. Morphine, most widely used and studied opioid in children, safe and effective in all ages, can be given by oral, subcutaneous, intramuscular, IV, epidural, intraspinal, and rectal routes. Continuous or intermittent infusion of the dose is adjusted according to individual analgesic requirements. And for making continuous infusions, we usually take 1 mg per kg of morphine with 50 ml normal saline. So that makes it 1000 mics in 50 ml of normal saline, which is 20 mics per ml. And we infuse it at 1 to 2 ml per hour. So the final dose delivered will be around 20 to 40 mics per kg per hour. Infusion regimens, 0 to 1 month, the maximum of 5 mg per kg per hour is infused, which comes to around 0.25 ml per hour. And 1 to 3 month kids, we go to up to a maximum of 10 mg per kg per hour, which is a maximum of 0.5 ml according to the dilution which I showed you, 0.5 ml per hour. Over 3 months, we go for a maximum of up to 40 mg per kg per hour and a maximum of 2 ml per hour. And patient control analgesia is also used in children as young as 4 years. And in further younger children, nurse control, NCA is nothing but nurse controlled analgesia, which is very commonly used abroad. And in fact, in nurse control analgesia, we can use a higher dose because there's going to be someone who's going to be monitoring the child. Fentanyl is indicated for morphine intolerance, nausea and vomiting, and for patients who have poor renal function. But fentanyl is not as innocent as it looks. The respiratory depression effect of fentanyl is going to be staying for a longer time than the analgesic effect. So whenever we use fentanyl, we have to have that in mind. To make infusions of fentanyl 50 mg per kg is taken and diluted in 50 ml normal saline, which makes it a 1 mg per ml of infusion, and we infuse that at 1 to 2 ml per kg per hour. So in case if the child is 2 kilos, we have 100 mics in 50 ml, which is 2 mics per ml. And when we infuse at 1 to 2 ml per hour, the child gets delivered of 2 to 4 mics per kg, 2 to 4 mics per hour. Epidural regimens, infusion, strength of around 0.1% ropivacaine is used with 2 mics per ml of fentanyl. And the rate of infusion is mostly 0.2 to 0.4 ml per kg per hour. We use a lot of combinations for acute pain in pediatrics. fentanyl and morphine for longer procedures. Fentanyl starts acting immediately and the action wears off immediately. We also combine morphine with fentanyl because morphine takes at least half an hour to start acting and it acts for a prolonged duration of time. We also like to combine dexmedetomidine and ketamine, where dexmedetomidine causes bradycardia and ketamine, increases the heart rate and that compensates. Ketamine and propofol. Ketofol has been a long-time favorite. Again, fentanyl plus propofol. Fentanyl has also been a long-time favorite. And ketamine plus midazolam, we've been using it for a long time. So these are the combinations which we often underestimate, but it's fantastic. The combinations do wonders in these kids. So coming to an end, common to all procedures, preoperative discussion is very important. The importance of pain control, options have to be discussed if they're older children. Anxiety has to be acknowledged. We have to acknowledge the emotional response of the child. We have to give choice to them. Intraoperatively, systemic analgesia, balanced multimodal technique has to be followed. Use a lot of paracetamol, NSAIDs, and opioids very judiciously. Consider local anesthetics, ketamine, dexmedetomidine. Always try to consider dexamethasone. A local or regional technique whenever possible, wherever there is a nerve, please do block it. Post-operative, PSU, always travel with an opioid. Consider infusions whenever possible. It's not as dangerous as it looks. With proper monitoring and trained staff, infusions are very good. So finally, optimal pain management is the right of all patients, and it's a responsibility of all health professionals to deliver it to children. Thank you. We're also proud to say that the 14th National Pediatric Anesthesia Conference is going to be held in Kovai on February 10, 11, and 12, and it's going to be a very one of its kind for India's first sustainable medical conclave. We're going to have a lot of networking, pediatric anesthesia treasure, and we're going to have a forest trek. The whole conference is going to be jungle themed. So it's an opportunity for all of us in Tamil Nadu. Please do make use of it. And we also run a one-year fellowship course in GKNM. It's an IAPA accredited one-year course. We have 2 seats, August and February intake. And we also have a part of the fellowship course, international observership opportunities. Thank you so much. Thank you so much for the opportunity. Thank you, sir.
Thanks a lot, Dinesh, for that wonderful and crisp talk. I know everybody got the point that pain is important in the pediatric population specifically. Dinesh, only one thing I want to ask, are you using this intranasal route for the pediatric in your setup?
Yes, sir. We use it for a lot of dental procedures, sir.
Okay, so which medications you are giving intranasal mainly?
Intranasal, we are giving ketamine, sir.
You are giving ketamine. Okay.
Ketamine,
And you have
Dexmed also.
Have that? Dexmed.
We have the atomizer. We have the
atomizer.
It is available online. We can order it.
Okay.
It is available online, sir.
Okay. As such, intranasal, as such, not much medicines are available mainly for the baby. Probably, I think you are using that what Dexmed comes, that you dilute it and give it, right?
Dilute it and give it.
Very
often we use it because for dental procedures, parents are very skeptical about putting an IV line and doing the procedure. So when parents are very concerned, I think ketamine and Dexmed, it's very safe to use intranasally. So far, we've not had any troubles.
Okay, good. One more question from my side. When you have mentioned about the ketamine for the local infiltration in the tonsillectomy, how do you dilute it, or what will be the dose, or how you'll be giving?
So we take 1 mg per kg, sir, of ketamine. Okay. We also mix it with atropine.
Okay.
Ketamine with atropine, so that the long-term effects of glycopyrrolate is avoided, and that is infiltrated locally, sir, for the post-tonsillectomy kids.
Okay.
Why atropine?
Ma'am, we try to avoid glycopyrrolate because it causes hot flushes, and the children feel dry mouth for a very long time, ma'am. And also the parents, they're very anxious about they think it's fever, and the child keeps asking for water. And
do you have increased secretions even with infiltration?
Yes, ma'am. Infiltration also we have.
Because it's going to be slow absorption.
Because a lot of vessels are nearby, I think initially we were having some trouble, and then once we started adding atropine, we were sorted. So
Very good presentation.
But what about the Dinesh? What is your choice in your hospital? Like I have seen that easy infusion techniques for morphine and fentanyl. What is your personal choice? Is it morphine or fentanyl?
sir, I
Post-op,
personally
post-op.
post-op, I personally prefer fentanyl, sir.
You're giving fentanyl infusion.
Personally prefer fentanyl, sir, than morphine. In child trust, how do we do it, sir? How do you do it?
So child trust, we are using more of morphine. I think we have a very good faith in morphine. Patients are the common, specifically all this abdominal surgeries and all. Definitely the morphine, apart from this one, bowel, your gut motility will reduce. So even surgeons are very happy with the morphine infusion compared to the fentanyl. And probably it's a quite old drug. So I am using it from last 12 years, but my probably Dr. Ramesh is using it for last 30 years. And I think he's not, only issue is the giving it in the proper, you should have the one technique or one dilution for your own hospital. You should not go away from the dilution. Because if it is
nurses are also familiar
exactly.
with,
Yeah. I have seen your presentation 1 to 2 ml per kg, but no, we follow 1 ml per kg. That's nothing. So you dilute your dilution as per this one, as per your weight. But you make sure that sister has to give 1 ml. So in my hospital, if somebody gives them no, pain is there, give it 2 ml, sisters will deny it. They will go, no, it's morphine infusion, only 1 ml. We are taught only 1 ml. So we follow that one. So any questions are there, madam? We'll see any chat box. I didn't see.
No questions.
There is, I think, some.
The role of melatonin in pre-medication in pediatrics. What is the role of melatonin in pre-medication in pediatrics?
Dr. Dinesh?
Melatonin, I have no experience, ma'am. I have no clue.
Madam, even we are not using it, madam, but yeah, I have used it only for some bigger kids for the MRI and all, who are little cooperative but who are little anxious. But as a pre-med in this one, we are not using. We are more comfortable with the still pediclorin, because people like all my staff, everybody, they are more used to it. But probably that is upcoming one, and we have to do it. We don't have much experience now at the right time at this point of time.
Pedicloral, they say it has some carcinogenic effects these days, so people are trying to avoid pedicloral.
That's the reason melatonin is coming. But anyway, we did. I know carcinogenic effect. Really, to comment on that one, we really don't know. But melatonin, probably that is the reason it has come into the picture. I have used only in the MRI setup. We are planning to use it now.
Dr. Subbulakshmi, have you used melatonin? Because you have raised the question. Do you have any experience with the melatonin?
Dr. Subbulakshmi? No, I don't think.
Sudarshan, sir. I think Sudarshan, sir.
No,
Okay,
I haven't.
No.
No experience.
She says no.
So, okay, there are other.
Anybody else has used melatonin? What is the commonest pre-medication all of you use?
Dinesh?
What do you use?
If the child has an IV line, we take the
child. That they don't have an IV line.
If they don't have an IV line, then I mostly go with the intranasal dexmedetomidine, 1 mic per kg.
How long do you wait?
We wait for 15 minutes. 15 minutes is good enough for dexmedetomidine. In fact, we do dental procedures just with intranasal dexmedetomidine.
You have 5 cases on the list, then
15 minutes, yes. By the time they finish, maybe we'll have to.
No, in that case, madam, we have to shift to the OT, like probably OT in the sense free holding area, and you have to do it. And I do little differ from a 15. Sometimes it takes almost 30 minutes. Minimum 30 minutes for this one. 50 to 30 minutes you have to take it. We also use Dexmet only, and we have to hold the whatever said and done. Small kids, they won't accept. That's the reason I was asking about the intranasal route only. Still they will, because we don't know the exact dose is going. If they suddenly move, the dose will not go. That is the problem. But yeah,
another trick there is, most often these children tend to spit it out or do things like that. So we take the child in give them CO inhalation, and then once we just put some drug into their nose, it works very well.
Then how can you take them to? They're not going to come in.
Yeah. I'm saying, ma'am, in case we don't have an IV line and they're good enough to walk, we have to do the procedure and we need some analgesic. Just keep some CO inhalation and then put the drug intranasal. They tolerate it better than when they are awake.
Okay, some more.
Because I still use pedicloral and I'm quite very happy with that. So.
Yeah, even same with us. Either it's a pedicloral or a Dexmet. These are the two things we are using in our setup. Either pedicloral. Pedicloral being, as I told you, everybody is very comfortable with, but we have to use at least 45 minutes to 1 hour. Then they are quite this one.
But that is quite safe to give it in the ward. So you can.
Exactly.
No, it's just the timing of the ward.
Dexmet, if you are giving, madam, we are never giving in the ward. We are giving only in the holding area. I think there are some more questions.
Sudarshan sir, I have a question for you. Can I ask you?
Yeah.
Since you moved to remifentanil, how is your experience with remifentanil in pediatrics, sir?
Remifentanil in pediatrics, we don't do much of a long pediatric cases other than ENT related tonsils and other things. So we don't really use much of remifentanil in children. I don't have, but other adults we use. But remifentanil, as you say, it's a very short acting, ultra short. So once you switch off, you forget the benefit of analgesia. So you will have to automatically add in other painkillers right from the beginning, either in form of non-steroidals or morphine or something to provide long-term pain relief for these patients, because they start screaming moment you stop remifentanil, 10 minutes time. Of course, the airway balance is extremely good. They don't cough, they don't do anything nasty to you when they wake up. But then once they wake up, they start realizing pain. It's really a nightmare to start catching up from there. So you'll definitely have to preempt them with the long-acting pain relief during the time of surgery itself, so that when the child wakes up or adult wakes up, you have a better analgesia on board. So that's the thing. But remifentanil, it's good for intraoperative, but it doesn't have any role after that.
Dr. Dinesh, I think there are certain questions in the chat. We'll try to get them quick. What are the drugs available in India to be used in intranasal route? I think I was also worried. Do you know any drugs specifically available as intranasal route?
I think only midazolam is they have a formulation for intranasal.
Exactly. Apart from that one, I don't.
Apart from that, it's all off the books.
There is from Dr. Shantini, there is some question. There was some concern about neuronal vacuolation in pediatric with the ketamine. Is it only theoretical?
Ma'am, most of the studies have been conducted only in rats and mice, ma'am. And that also, it's 10, 20, 30, 40 times the therapeutic doses which has been tested on the rats. So I don't think we can extrapolate those results to human beings. It's always a controversy, ma'am. So as long as we think there is some advantage with the children, I think we can proceed using that.
True, Dr. Shantini, and probably other thing is ketamine, what is used in the pediatric is mostly as an analgesic dose they are using, not as an anesthetic dose. And in that one, definitely was. We are using the quite low dose, 0.5 to 1 milligram per kg.
And no study has been conducted on children, actually. Everything has been on animals and extrapolated to human beings.
Okay. Dr. Shikha wanted you to repeat the dose of atropine and ketamine combination.
Ketamine, we take half cc, which is 25 mg, and atropine, we take half cc to mix it, and we dilute it to 2.5 cc. So each ml is like 10 mg. So that's how we use it. Half cc ketamine, half cc atropine, diluted to 2.5 cc, which makes it 1 mg ketamine per ml, and even distribution of atropine, and we use it.
Dr. Sudarshan wanted to know, I think, the role of any fentanyl lollipop.
Sir, not
I
available.
don't think, sir, it is available here. Yeah, but I think if it's available, it probably will be a good. Yeah. Dr. Jayalakshmi wanted to know what sedation you prefer before blocks to make the pediatric patients cooperate.
And mostly we perform blocks under GA, ma'am. So I think pretty much we are sorted there. We don't do awake blocks in children mostly. So, yeah.
Exactly. I think that is the difference between the adult and pediatric. The pediatric is always a GA plus regional, GA or at least
Never do a,
yeah. If you be elder children, probably you can, with the mask itself, you can give this ketamine I'm telling 0.5 to 1 milligram per kg, and sub-anesthetic dose of propofol, that just to sleep them till you give a block. I am specifically telling ketamine because when you are giving block, at least for that pain relief, so till the block works. So, Dr. Sudarshan is there any children where you require OFA or opioid-free anesthesia? What's your recommendation?
So we try to do as much OFA as possible, sir, with blocks and just sedation. For example, if we have to do a hernia, we try to do it mostly with a caudal and some sedation with a mask or an LMA. We try to avoid opioid as much as possible, sir, because it's going to affect the whole body. Then, like slide I showed.
True, I think most of the daycares, I think people who specific all pediatric setup, the opioids are least used when you are giving all this.
And unlike adults, we don't use 2 mics per kg, so we use just 1 mic per kg. Even if at all we have to use an opioid, 1 mic per kg of fentanyl is more than sufficient, and it acts for nearly half an hour to 45 minutes. The analgesic effect comes to around 45 minutes. So I think that is more than sufficient, sir. If at all we have to use an opioid, but we try to avoid opioid as much as possible for obvious reasons.
Dr. Kalyan wanted to know what's your preferred route of NSAID administration?
So both IV and per rectal. Per rectal, we have diclofenac suppositories, which is 1 mg per kg. And IV, we have ketorolac. Ketorolac, we use 0.5 mg per kg. And the advantage of ketorolac is we can use it even in preterms. Even 2 kilos, 3 kilos, we can use ketorolac, 0.5 mg per kg, where you can avoid opioids. So ketorolac IV is a very good drug in our armamentarium for newborns and preterms, where we have to avoid opioids.
True. Dr. Giridharan wanted to know role of intramuscular ketamine in pediatric. I think I don't think anybody is using it, but anyway, still from Dr. Dinesh.
The problem with intramuscular ketamine is once you give an intramuscular ketamine, the child becomes so anxious to an injection that next time when they have pain, they say they don't have pain, just fearing the injection, IM injection.
No, I would say no to the intramuscular ketamine. I think in last 12 years, I have not given intramuscular ketamine in pediatric. Dr. N. Mahajan, pain management in a mentally retarded child is challenging. How you do it?
So sometimes when there is no other option, it is only brute again, sir. Brute again combined with.
That's true, but I think why I don't know Dr. Mahajan's feeling is challenging. Yeah, mentally retarded child, that doesn't mean that you can give your whatever the analgesic you are using for other things also. Probably opioids you have to give less, but all regions, everything has to be given. And definitely you are going to make them sleep to that mind. So then after that, probably whatever your regular, what your presentation can be given. I don't think there is specific any problem with that. Any other? Oh, I don't think. So I don't think any other questions, sir. Yeah, we should wrap up. I think what I feel is the holistic approach is more important, and what I like it from Dr. Dinesh presentation. It's a multimodal. Actually, most of the people we forget again that the multimodal analysis is more important, and on the clock and before. I feel pain, you don't have to wait for pain to come in. Children's even in my setup also sometimes children, once you give written paracetamol and NSAID suppository, sisters feel that okay, both by mistake doctor has written or something. So he'll try to give one paracetamol, wait if the pain is there, and then he'll give. So I feel multimodal analysis is more important, and paracetamol has to be given really good importance for in this one with the safety and all. As Dr. Dinesh also has already mentioned, the dose probably underdosing is very common with the paracetamol. We still wanted to give as like an antipyretic dose rather than the analgesic dose. So that probably we have to understand. And after analgesia also, what do I mean by the holistic approach? Even the recent 2 days back, we have the bladder augmentation surgery and all. With the epidural going on, still the child he is probably a 12-year boy. He's still complaining and he's not happy. Parents are again calling. Basically, the child was so anxious, we just gave them anti-anxiety medication. Apart from this one, epidural, he became perfectly all right. So probably apart from the pain, we have to think in children specifically. We have to think about the other thing, anxiety, and probably the smaller kids feeding. Early feeding is more important. That's what I think from my side. Dr. Sudarshan, anything specifically from you?
I think you nicely summarized and wrapped it up. I think I have nothing much to add. I think everything has been most of the discussed well. I think Dr. Anandi, if she has anything and anything to conclude, closing remarks by the chairpersons, and we'll go to the next session.
Dr. Anandi, anything, any remarks from
I
you?
think we are.
Thank you both speakers and moderators
Thanks for
sparing
having
your
us here.
time and participating in the event.
Thanks, sir. Thanks for having us here.
Thank you, sir. Thank you, everybody. Thanks to the speaker and as well as for the moderators, and thanks for our academic chairman, Dr. Susan Kasturi, for moderating this, for heading this session. Now, I would like to put the next part of the program that I call upon our secretary, Coimbatore City Branch, ISC City, Coimbatore City Branch Secretary, Dr. Srinivasan, to present the City Branch reports.
Yeah, good afternoon all. On behalf of ISA Coimbatore, I thank the state office bearers for giving this opportunity. We at ISA Coimbatore, we were conducting online meetings every month during the COVID era, and now we moved into physical meeting almost every month, other than the months wherein this national and state conference were held. We even had one yesterday. It's a mixed crowd of both the PGs and the practicing anesthesiologists. And we motivate the PGs to, become a permanent ISA member, life member. And we are almost successful in it. And we are planning to conduct one our Easter Day celebration as a family get together in October second week. I thank both the speakers, Dr. Dinesh and Dr. Venkatesh, and the moderators, Dr. Narendra and Anandi Arul Madam, for your time. And I thank once again everybody on behalf of ISA Coimbatore. Thank you, sir.
Thank you, Dr. Srinivasan. It's very nice that you are making the Easter Day celebration as a family meet. It's a very good idea. I think every branch should take this initiative. Before going to the closing part of the session, I would like to ask our President, sir, Kumar sir, any other thing that has to be mentioned in this meeting, sir?
Nothing, Bhaskar. Everything is fine. Only thing is in the UA Isakan, please inform your branch members about the participation in National CME program on October 14 and 15. The speaker should be less than 40 years and chairperson should be more than 40 years. Chairperson not an issue. Many are there. And we have to encourage that younger speakers to participate in National CME. So whoever is interested to participate in the National CME, please enroll their names, their interest on any particular topics or debates or pro-con or whichever format. So 1 hour is allotted for ISA Tamil Nadu. Please inform all the branches and all our members of ISA Tamil Nadu to participate in that CME program. I think with this, we had an excellent academic program and Sudarshan sir did a fantastic job. Thank you all the speakers and moderators. I think we can go to the vote of thanks. You please proceed, Bhaskar. Thank you.
Thank you, Mr. Sir. Now I call upon our Honorary Secretary, ISA Tamil Nadu, Dr. S. Giridharan, to present the vote of thanks.
Good morning, all. On behalf of the Tamil Nadu ISA office bearers, I would like to thank the senior anesthesiologist and past and present office bearers of Tamil Nadu ISA for recording working with us for this CME program. I thank the speaker G. Venkateswaran, Ganga Hospital, Coimbatore, and Dinesh Kumar Gunasekaran, Kuppuswamy Naidu Memorial Hospital for accepting and giving a good lecture regarding the talk. And I also thank the moderators, Dr. Anandi Arul, Vedanayagam Hospital, Dr. Narendra Kanji Kamachi Children's Hospital for moderating this session, and as well as making the discussion a very live and active one and an informative thing too. I thank Coimbatore ISA, the President Saravana Kumar and Secretary Srinivasan for coordinating with Tamil Nadu ISA for the CME event. I also thank all the delegates and postgraduates who were the part of the CME program. I thank A1 Logistics for the audiovisual coordination. I thank Neon for sponsoring the CME. And I also thank the God Almighty for making the CME a grand success. Thank you all.
Thank you, sir.
Thank you.
Sir, this we can come to end to the session. Thank you, everybody. Thanks.
Thank you.
Thank you.